Evaluation and management of benign prostatic hyperplasia, BPH. Benign prostatic hyperplasia, BPH, is a common condition in aging men characterized by the non-cancerous enlargement of the prostate gland. It can lead to lower urinary tract symptoms, LUTs, which can significantly affect quality of life. Below is a detailed overview of its evaluation and management. Evaluation of BPH. 1. History taking. A comprehensive medical history is crucial to differentiate BPH from other causes of LUTs. Key areas to explore include urinary symptoms, obstructive symptoms, e.g., weak stream, hesitancy, straining, incomplete emptying, irritative symptoms, e.g., frequency, urgency, nocturia, impact on quality of life, use of tools like the International Prostate Symptom Score, IPSS, to quantify symptom severity and bother. Medical and surgical history, history of urinary tract infections, hematuria, or urologic surgeries. Use of medications, e.g., anticholinergics or sympathomimetics, that can exacerbate symptoms. Sexual function, assessment for erectile dysfunction and ejaculatory dysfunction. Family and social history, family history of prostate conditions or lifestyle factors like alcohol or caffeine intake. 2. Physical examination, digital rectal examination, assess prostate size, consistency, and tenderness. Identify any nodules or irregularities suggesting malignancy. Abdominal examination, check for bladder distension. Laboratory tests, urinalysis, to rule out infection, hematuria, or bladder pathology. Prostate-specific antigen, PSA, used to assess prostate volume and screen for prostate cancer in select patients. PSA levels may be elevated in BPH, prostatitis, or prostate cancer. 4. Imaging, ultrasound, transabdominal or transrectal ultrasound, TRUS, for prostate volume measurement. Assess residual urine volume and rule out upper urinary tract obstruction or bladder stones. Other imaging, CT or MRI in complex cases or when malignancy is suspected. 5. Urodynamic studies, recommended in cases with unclear diagnosis or prior unsuccessful treatment. Measures parameters such as bladder pressure, flow rate, and detrusor muscle function. 6. Cystoscopy, used in selected cases to evaluate for urethral stricture, bladder neck obstruction, or bladder stones. Management of BPH. The management of BPH depends on symptom severity, impact on quality of life, and complications. Approaches range from conservative measures to surgical interventions. 1. Watchful waiting, conservative management. Appropriate for patients with mild symptoms. IPSS score WA7. Includes lifestyle modifications, reducing fluid intake, especially before bedtime, avoiding caffeine and alcohol, bladder training exercises. 2. Pharmacological management. Pharmacological options are the first-line treatment for moderate to severe symptoms, IPSS Koshari 8. Common classes of medications include A. Alpha blockers. Examples, tamsulosin, alphazocin, doxazocin. Mechanism, relax smooth muscle in the prostate and bladder neck to improve urine flow. Onset, rapid, days to weeks. Side effects, dizziness, fatigue, retrograde ejaculation. B. 5-alpha reductase inhibitors. Examples, finasteride, dutasteride. Mechanism, reduce prostate size by inhibiting the conversion of testosterone to dihydrotestosterone, DHT. Onset, slower, 3 to 6 months. Indication, best for men with larger prostates, 30 milliliters. Side effects, decreased libido, erectile dysfunction. C. Combination therapy. Combining alpha blockers and 5-alpha reductase inhibitors can be effective in men with severe symptoms and large prostates. D. Phosphodiesterase 5 inhibitors. Example, tadalafil. Indication, BPH with concurrent erectile dysfunction. E. Antimuscarinics. Examples, oxybutynin, tolterodine. Indication for irritative symptoms like urgency and frequency, often in combination with other therapies. Cat 3. Minimally invasive therapies. Recommended for patients who fail medical therapy or prefer minimally invasive procedures. Transurethral microwave thermotherapy, DUMT, uses heat to shrink the prostate. Transurethral needle ablation, 2NA, uses radiofrequency to ablate prostate tissue. Prostatic urethral lift, PUL, mechanically lifts and holds the prostate lobes away from the urethra. Water vapor therapy, ablates tissue with steam. HAF4, surgical management. Indicated for patients with severe symptoms, significant obstruction, or complications like recurrent urinary retention or bladder stones. Transurethral resection of the prostate, TRP. gold standard for moderate to severe BPH. Removes excess prostate tissue via a resectoscope. Laser therapies. Holmium laser enucleation of the prostate, HOLEP, effective for large prostates. Green light laser. Vaporizes prostate tissue with minimal bleeding. Open prostatectomy. Reserved for very large prostates, 80 to 100 milliliters. Other techniques. Bipolar TURP, or robotic-assisted surgery. Follow-up and monitoring. Regular follow-up is essential to assess symptom progression, medication side effects, and complications. Repeat PSA and imaging may be necessary for monitoring prostate growth or detecting malignancy. Conclusion: BPH is a manageable condition with a wide array of treatment options tailored to the patient's symptoms, prostate size, and overall health. Shared decision-making between the patient and healthcare provider is critical to achieving optimal outcomes.